It's a pleasure to join the AeHIN community today. What I would like to present is about DRG in Thailand, why it is important. So I start with the objective of the first bullet is converging policy on the universal coverage, and follow with the healthcare financing tools or the payment method. Then what DRG, then the maintenance of Thai DRG, and how the DRG used to estimate resources needed for patient care, DRG and the data, and with the conclusion. The converging of the universal health coverage policy around the world, we can trace back more than 100 years ago that in 1983, it was the Bismarck model of health insurance in Germany that started to provide the coverage to the beneficiary. And in this slide, 1911, the UK National Insurance Act that was the first act to provide the coverage, but that was for the primary care only. Up to 1948, it was the beverage model that being proposed 4 years earlier in around 1944, that after the World War, then the UK implemented the beverage model in the UK that cover both primary care and also the hospital care. Then we can see that the beverage model and the Bismarck model and beverage models spread throughout the world to the high income and the middle income, and also some of the low income countries, such as the Sri Lanka. We can see that the coverage, universal health coverage in Sri Lanka is follow the beverage model of the UK. If you look at the WHO declaration in 1978, it was the WHO proposed health for all by the year 2000, and using the primary health care to provide coverage through the primary health care system. And in the year 2000, the WHO report on the it was the report that used the terms universal health coverage to propose that all the nations should provide coverage to the population. In the 12th December 2012, the United Nations started the policy of the UHC Day. That means international agencies now very much endorse on the UHC. And if we observe the World Bank policy, they changed the positions from the cost recovery before the year 2000, and the World Bank finally accept the policy of the inclusive and the equity policy that means it support the UHC. If you look at the innovative of healthcare financing tools, the payment to the healthcare providers, individual healthcare providers or the institutions. The traditional model is the salary and the fee for service. And when the primary care system start, then the capitation was the strong payment in the UK. And if you look at the resource allocation working formula, this is to ensure the equity allocation of public resources. We can trace back to the ROF formula in the UK in 1976. For DRG, the first publication on the DRG was published in the Medical Care Journal in 1980s. And 3 years afterwards, DRG was used for the prospective payment in the US Medicare scheme. When DRG was published and being spread throughout and used as the demonstrate case in the US, we can find the application of DRGs in Australia. There was a publication in 1992, the New South Wales resource allocation formula. We can see that DRG has been used in the resource allocation formula. And this is the method of funding with the more or less, we can say that global budget, not the open end like in the US Medicare system. When we saw the global budget policy and practice in Australia, so that can very adoptive in Thailand healthcare policy. The publications of migration of DRG for the managerial innovation diagnosis related group was published in 1993, and this is a proof that DRG has been spread in Western European countries. And another payment method that especially for the primary care rather than the capitation, we can see the quality outcome framework, or the QOF, is another method of use, payment use in 2004. And the terms of value-based healthcare was began in 2010. But if we trace to the payment according to the DRGs, especially in the CMS or Center for Medicare and Medicaid Services, DRG somewhat has been proposed as some practice of the value-based healthcare. As the publications of migration of managerial innovations after 10 years of DRG's practice in the US, the situation in Thailand, why we start doing the research on the DRG, because fee for service payment is too expensive, as we know. And in Thailand, we start capitation payment in the Social Security scheme. It was the first capitation payment for as a contractual prospective payment for the compulsory or social health insurance. But the experience, we found that using the capitation payment or the I would like to use the term inclusive capitation. That means include outpatient and also the inpatient. The inclusive capitation is introduced the underutilization, especially for the inpatient care, and we found the very low admission rates in the working environment or the working population in Thailand related to the Social Security capitation payment. So we go into the introduction of the definition of case mix and DRG, and some of the developments of DRGs in Thailand. So what is DRG? As the publication of Professor Robert Fetter in 1980, DRG is the patient classification system for acute care. It's classify patients into the ISO resource group. That means they use the resource of bed day, length of stay, the same homogeneous length of stay in the hospital, and also the homogeneous cost. The patients in the same DRG, we have the same length of stay and the same level of hospital resource use. And it has been used in the US prospective payments since 1983. The general principle of the DRG, as Professor Robert Fetter, he was an industrial engineer, so he looked at the hospital information that there are certain group of hospital information that can describe the hospital product. They are the principal diagnosis and procedures, operating room procedures, which within the informatics, we can group them or code them into the ICD. And at the time of development in Thailand, around research development in 1993, we had coded the diagnosis into the ICD-10. And we start coding the procedures in the ICD-9-CM. The DRG's engine will use the certain so diagnosis and procedures, and for the diagnosis, we also had the make use of the comorbidities and the complications, and the patient's age, patient's birth weights according to the neonates, and patient sex and discharge type. These are the data that used for classification of patients into DRG. And within DRG, the patients will be mapped according to the organ system into the MDC, or major diagnostic categories. As the definition of DRG is the one of the patient classifications, but if you look at the generic term of patient classifications, we can use the term of case mix. So the case mix cover many kinds of patient classifications that used to estimate the resource use, and the essential meaning is the cost homogeneity. And there are several kinds of case mix other than DRGs, because DRG focus on inpatients, acute care. if you want to design the payment to cover varieties of healthcare provisions, then you may consider to have outpatient case mix, for the per person per year, or the outpatient case mix that's per visit. For chronic care, like psychiatric patients that have a different cost structure, then the psychiatric case mix is another case mix of to pay for the psychiatric patients. And in Australia, the SNAP, or the subacute and non-acute patient classifications, also very prominent in using for paying chronic and subacute care. For the experience in Thailand, we start research on the DRG in 1993. We start with the accident and emergency at the time, because we passed the law on the Traffic Accident Protection Act, but within the act, it designed the payment system to use the fee for service. So it was the opportunity to introduce the DRG research. And within the first research that we got funding from the Health System Research Institute in Thailand, we focus on the AeHIN DRG. And within the AeHIN DRG, we describe the disease group around 100 groups, using the logic of the US DRG. After that, we research to cover all of the patients using the logic of the US DRG. Then we had around 500 DRG groups. In 1999, it was the first opportunity that we introduced DRG to pay to the hospital. And at the time, we just pay because of the limited budget and the budget that we have extra budget for the low income card scheme. Then we apply the DRG to pay for the high cost care for the low income card scheme. That means the DRG relative rate higher than 3. When Thailand introduced the universal coverage policy in 2001, then our DRG system has been mature to the version 2, and a few years after the implement of the universal coverage policy, because we want to include the teaching hospital, because teaching hospital tends to be high cost. Then in 2003, we changed the DRG versions to version 3. Then we have around 1,200 DRGs to pay to the hospital, including the teaching hospital. The increase in the number of DRGs, it was because we shift the logic from the US DRG to the Australian DRG, because Australian refined DRGs had the principle of describing severity level. In 2010 and 2017, then we deliver later versions of DRG to the version 4, version 5, and version 6. And you can see the number of DRGs can increase or decrease. It's according to the logic or the classification trees within the classification logic, that in every version we consult with the clinicians from the Royal College of physicians, of surgeons, OBGYNs, and so that during the revision of the DRG, we try to amend what the comments from the clinicians. So the different characteristics of Thai DRG. The first two versions, it's based on the HICFA DRG or the US DRG. Start with the 2002, we shift to the AR DRG, Australian Refined DRG. And for version 4, we introduce the bilaterality and multiplicity of the procedures, and we expand we extend the ICD-9CM, which normally it's 4 digits coding, to be the 6 digit with the extension to address for the bilaterality. That means left eye or right eye, or the multiplicity. That means procedures that's been done at the second time or third time to the same organ. And version 5 and then version 6. The change of every version, as I said before the change, we ask for the comments from users or providers. After before the launch of the change, then we publish the relative rate, which is the currency unit, the standardized currency unit to all of the stakeholders. And every change of the DRGs, we face the difficulties. That means the fighting between big hospital and the small hospital, that because they are losers and gainers. So from research to institution, how the DRG created. This is the example, like the researchers from Yale University, and then it handled to the financing body, like healthcare financing administrations, and then the CMS in the US. But in Thailand, we start from the research institute, we get the funding, and we start as researchers. And now we try to institutionalize. Then we have the Thai Case Mix Center, but it's now come back to the Health System Research Institute. But we rather want to be another autonomous, because the research component may not be as strong as the HSI. But within the updating of the each version of DRG, then we have the step of reclassification. That means this is based on the clinicians' comment, and the recalibration. This is based on the evidence that we collect charge data from the hospitals. The entry point of Thai DRG into the universal coverage in Thailand. In the year 2001, the government had the policy of universal coverage. Then in the year 2000, as I said, the year of the 1993, we had the Social Security scheme that allocate according to the inclusive capitation. It include outpatient and inpatient within the same capitation. But as we found the under provision of admission, then we research on DRGs. And we propose that inpatient care should be allocated on the DRG basis. Then the first version of model of separation of inpatient budget. It was because of limited available at the time, and the government want to make it fast. Then the first allocation of DRG with the global budget, the budget for inpatient care was only less than 30% of the total capitation. And in the first few years, because of reluctance of the NHSO or the National Health Security Office, then we found two ways of allocation of budget. That means half of the provinces in Thailand still stay with the capitation, and the other half have DRG for the allocation of a capitation budget. So the exclusive capitations experimented in the half of the provinces. The national, that was because this is the example of the political decision or the technical readiness. The NHSO, the National Health Security Office, just set up in a year after, that means in the year 2002. And the research of the Sirivan Pitiyarangsit saying that, documented that there was a reluctance that in some of the informants, key informants, saying that the DRG tools is not incomplete. It's incomplete and it's not very ready at the time, or the comments on the IT environment. But because the benefit of the population at large, then the politicians who became the government at the time made the decisions on the macro scenario, and they want to see the implementation quickly. Then the NHSO, which is the governance board of the implementations, weighing that the political benefits would be far more than the just listen to the hospital, then that decisions was quite fast. And in terms of the economists in the healthcare reform agenda, the economist think tank saying that DRG is the tools that make the information symmetry. It's demystify the medical environment, that it can be used as the policy dialogues and payment to the hospital. This is example of DRG version 6, the latest version, that the very complex clinical information is translated into the DRG numbers according to the organ system, according to the operative medical DRG or surgical DRG, and expressed on the severity index on the 5th digit. 0 is not severe, 1, 2, 3, yeah, up to 4. 4 is the highest complexity. And we have the relative weight. We have the relative weight here, and we have the length of stay for each DRG condition and the outlier trim point. And the calculation for converting into the payment is according to the base rate. And the base rate should reflect the cost of care. Like example of this DRG 01010 craniotomy for trauma, and the relative rate is 4.1. And if the base rate is 8,000 baht per relative rate, then the hospital will get this amount for treating the patients. So the calculation of relative rate is very important for the hospital to attend. In general case, we use the arithmetic means of that specific DRG and divided by the cost of all of the cases. And for some of the referral formula, some may suggest that we should use geometric means because it's the average seems to be not normal distribution. So this some of the technical context. As development of our Thai DRGs for version 4, this was the example that before we make a split into the bilaterality, like a cataract of one eye or cataract of both eyes in one admission. After we have extend the ICD-9-CM to address this issue to be confident that the data is correct. The cost was a significant difference between one eye and two eyes. Then there's the decision to split the DRG. So we split DRGs for cataract, multiple cataract, both eye cataracts, and debridement, multiple screen graft, or the craniotomy. DRG has been used for the estimating the how much of the budget we should need for our universal coverage policy. Like this was 20 years back when we estimate the UHC policy requirement. We estimated from the admission rates back to 1992. It was the survey that the latest survey at the time that we used for estimating if we want to change the policy to be the universal coverage by the year 2000. Then we estimate the population change. We estimate the relative rate by age group and the cost per relative rate. Then we estimate the estimation if the policy to be changed in the year 2000 population change of the size and also the proportion. That means we have more elderly, and the elderly we have a higher relative rate, and elderly we have the higher admission rates. Then we estimate according to the relative rate by age group and the cost per relative rate. And the latest criticisms on the calculation of relative rates based on the hospital charge also very heavy. During we changed the DRG to DRG version 5 and DRG version 6. Therefore, we try to introduce the standardized or using the hospital information to estimate service item of the billing subgroup, like a CT scan is the billing, and then how much the cost allocated top down and bottom up by the service item to the patients. So finally, we are now working, perhaps the next version, we may use the cost to calibrate for the relative weights. This is example of cost of the recent studies that we can arrive at the cost, and the cost per adjusted relative weight. This is the message to the budget bureau or fiscal policy body that we should also be fair to the provider of the hospital to compensate for the, even though we use the global budget, we should have a better calculation of the base rate. And also we have to guarantee that the cost recovery of each scheme, as you already know that Thailand universal coverage policy is not the single payer. We have different three payers. So payers of the UC scheme, Social Security scheme, and the civil servants medical benefit scheme, they should have this reach the same of the cost recovery. So the cost, the ratio of the cost to charge, the cost should be a little bit lower than the charge. That means that should be fair to the between the funders to the hospital, and also the two of the beneficiary of a different scheme. So this slide just to show you that the use of DRG, because it's the average, then sometimes for the high, if the prescribing of cancer drug is not even, that means there can be a different protocol to treat the patients of a different type of protocol for the cancer care. Then the high cost medicines or high cost medical device can be unbundled out. So the rest will still within the bundle of DRG relative weights. And in Thailand, we also have the outlier reimbursement schemes. This is for the very expensive case, like the treatment of COVID-19. At the moment, we also can see different varieties of severities, and the average can be paid on the relative weight. But in some cases, the hospital had spent a lot of resources. Then for those cases, very extraordinary expensive case can be considered on the, that means we review individual case on the ORS or the outlier reimbursement scheme. So this is the to say just the limitation of DRG or the introduction of DRG for the new type of disease, or before we can include into the DRG payment system, then we may have a separate payment. So the mix of payments is still important to consider. So coming towards the end of my presentations, would like to focus on the data. So how DRG affects the data. So when we use DRG to pay to the hospital, then we need the standardized data sets. And now within the IT, more of informatics, then the health data standards become very important. And we may see how we may in the future go into the artificial intelligence in terms of dealing with the upcoding or the systematic flaw of the in the claim system. This is a schematic of the first version of our standard the standard data set, because at the time of around 20 years ago, we also realized that there was a HL7 standard, but the development was not ready for the implementation of the HL7. So we start just with the standard data set to address that how many important data element, data item that we need for the claims of DRGs. And if we want to move forward to the complex payment of complex primary care, then we may need the complex, I mean the case mix for primary care, whether the per person or per visit. So this was the publications, the proposal on how many more standards that we need to make a seamless primary care system, seamless and also seamless with the hospital care. So in conclusion, research activities build up the experience for DRG readiness in Thailand, and human resources with the variety of expertise are essential for the changes. Political decisions also very important, and at the time we political decisions were made for the limited resources. As I said, less than 30% of the capitation budget come into the DRG. But the fiscal policy should also be accountable to the costs that borne by the provider and also the quality of care. If we just contain the cost, then the quality of care to the consumers can be in a danger. So the calculation of base rate or the classification of a complex case from the not complex case is important for the maintenance of DRG. The updating mechanisms with the evidence and the transparency will make the DRG policy and practice sustainable. So that's my presentation. Now come to the Q&A.
Yes, thank you very much, Professor Supasit. To all our participants, our floor is now open to questions. I think we also have members of the health insurance organizations here. So if you have questions, please feel free to ask them to Professor Supasit. The mics are also enabled already.
Hi, Dr. Supasit, can you hear me?
Yes, yes.
Yes, good evening. Thank you for your presentation. I have two questions. We are moving towards ICD 11. And for procedure, I don't know whether we are moving away from ICD 9 CM. So how is that going to affect the Thai DRG? That's the first question. And my second question, what about the use of new technologies in treatment and so forth? So will that also have an effect on the DRG system? Thank you.
Thank you, Farida, for questions. We discussed a lot on the ICD 11, but so far, I mean, as I said, it's based on the evidence. If we don't have the evidence, then we cannot calibrate or cannot move forward. As the plan, then once if we migrate into the ICD 11, then we still have the crosswalk to the ICD 10. Then from this table, then we can make an update to the next version, the newer version with the new coding or the primary coding. Yeah. So no matter the diagnosis or the procedures, then the primary coding must come first, and DRG is the coding secondary, the classification. For the newer technologies, it's usually happens like the unbundled payment. If it is expensive and not evenly distributed, so it comes with the first of the fee for service. And once we found the patterns that it can be classified into the DRGs, then that means we have the information from many providers, then we can consider to fit into the DRG. That's my response. Thank you.
Thank you, Professor Supasit and Dr. Fazila. Are there other questions from our participants? I think we have Dr. Bunchai.
Hello. Thank you very much, Achan Supasit, Professor Supasit. Actually, Dr. Supasit is my mentor for many years. I just to ask, add to Dr. Fazila's questions that, to my knowledge, I act in many case mix communities, many meetings at the case mix communities. That do they have any case mix communities are now considering using the ICD 11 as the diagnosis, including into the calculation of the DRG. Up to my knowledge, there is no countries that are using the ICD 11 with their case mix or calculate the DRG. So many countries are now pursue maybe the route that staying at the ICD 10, and then they for the advance of the LIT, many countries are implementing SNOMED CT and then do the mapping to the ICD 10. So to my up to my knowledge, the DRG community, they still figuring out that how they are going to group the disease. Are they going to how they to migrate from the ICD 10 to ICD 11? That haven't any answer yet. But even those, we as the digital health communities, I think Malaysia has a very advantage on that because of you implement SNOMED CT in the early phase. So mapping back from the SNOMED CT, which is more granular to the ICD-10, even they are changed to ICD-11, that would be not cost much. That my first response. The second response for your question about the new technology, rather additional to the very new one. So the DRG cannot accommodate this kind of this technology costing scheme because of the very small or the very skew of the case. We have to have more many cases that we can do as the average. So they come up with Ajahn Supasit said that unbundle. Another, this make us to understand that the technology change every year. So the DRG are not static. It have to be updated in a few years. They have update, and the way that they update, they call the reclassification, which is how to group. The very good example is that before we do the cholecystectomy with open surgery, and in the early year, the laparoscope is quite expensive because of the instrument is very expensive. But after that, you can see that right now the open surgery is more expensive than the laparoscope or the minor surgery for the minor wound operation. Then the classification of the group are changing. That's my response to the two questions, adding to Ajahn Supasit answer. Over.
Yes, thank you, Professor. Dr. Bunchai, do you have any other additions to that, Dr. Supasit?
Yeah, I just see the questions in the chat, yeah. And
yes. We have a question from Dr. Celina. So the first one is, how did you convince the leaders or politicians and government to invest their resources on the DRG, and why is it worth pursuing?
Yes. So the response should be it is the systematic approach rather than individual approach. If you use the fee for service, then that would be the individual detailed payment that it's unaffordable. Then we try to convince the first one that in our experience, the research asking for research grants from the HSI or the Health System Research Institute, then we have to explain to the board members that this is the innovations that should be good for systematic approach. Yeah. And yeah, as I said, the symmetrical information. Economists try to argue on the asymmetrical information that make the market failure, like a market failure in healthcare. And this is the fundamental arguments for the DRG, try to convert complex things to be the negotiable things. That means information that group into 1,000 group of DRG of a medical product or hospital product. Yeah, so that's and like in my slides, once politicians seeing that this is a tool, politicians try to think about the containing the cost, but DRG developers try to defend that it's not the narrowed down to the just cost containment, but it can be used for quality benchmarking and many more, like efficiency or the equity also.
Yes, thank you, Professor Supasit. Dr. Celina has a second question. How did you decide upon your outlier reimbursement scheme?
So the practice of this is we make certain rules for exceptional loss. So it can be hospital group or like if it exceeds the loss to the hospital of 200% or so, then this is the cut-off point that the hospital can submit for the outlier reimbursement scheme. And if the hospital submit for the ORS, then the hospital must submit medical records for review.
Thank you, Professor Supasit. I think we have our last question. It's from Dr. Fauzi Zaidan Ali. Hi, Professor Supasit. What is your opinion on regional collaborative DRG or even global-based DRG like the WHO DRG? Thank you.
So the global can be very complex and can be large. We have experience of Nordic DRG because they are small countries, small in terms of number of populations, but they are rich small country. But we are in our regions, with the World Bank support in some a few years back, we have organize or meet together with the Southeast Asia DRG. We try. It's a good idea doing that, but how to make this activity sustainable? I think it's also related to the business model. How can we build up the sustainable business model to make our regional collaborations being sustainable?
All right. Thank you very much, Professor Supasit, for accepting our invitation to grace AeHIN Hour and for sharing your wonderful work on the DRGs. So to wrap up our session, may we now call on our chair, Dr. Bunchay.
Okay, thank you very much. I think we have a full house today, and thank you very much, Professor Supasit, for provide the opportunity to talking with us. I know that you are the one of the famous professor in not just in Thailand but in all the ASEAN and the case mix communities, and you have contributed to the both for the countries and for the region. And we hope, like Celina that said that AeHIN, Asia eHealth Information Network, are the sharing communities, and we hope that you someday the DRG can be a regional DRG that we can share with our neighbor countries using the similar algorithm or similar logic that can and hope that Thailand can be kind of the coaching another country to pursue this endeavor. We think this is the good for not for our country but also for the regions. And thank you very much to everyone to attend this. And in the next two weeks, I'm trying to relate it, what I have learned from Dr. Supasit about the DRG and the digital health and how we're gonna build the health information system that can be support the health financing tool like the DRG. With that, thank you very much, and hope that Ajahn Supasit or Professor Supasit can be with us in the next time. Thank you. Bye.
Thank you, everyone. Good night.
Thank you all.
Good night.